Thank you, and good evening. I came from Zambia to come and learn and possibly give hope to many people who are suffering, and especially that Africa is underrepresented in the burden of long COVID. My presentation is largely on the clinical presentation and epidemiology as well. We have done a number of studies in Africa around the seroprevalence. In Zambia, we did one of the surveys or the extent of COVID around the country. Then also early during the pandemic, we also saw that this was just 8 months into the pandemic, that people who suffered from COVID, they still had persistent symptoms as well. And we also had a high number of inflammatory markers as well associated with those persistent symptoms, and these were published. However, there are few countries that set up dedicated services for long COVID, and also we think that that is a gap. So because of those persistent symptoms which we saw among the patients that had COVID, we set up the first COVID-19 clinic. Then also we set up with support from the U.S. Center for Disease Control. We started having dedicated clinics for individuals with long COVID, and these clinics, we call them the post-acute COVID-19 or PAC-19 clinics. And because, again, of the nature of where we are, infectious diseases have a high burden, so we had to include bidirectional screening for TB, but also comorbidities as well, management in these PAC clinics. And we have 13 PAC-19 clinics in the country. We have the data recorded in REDCap for all the patients that we have seen in the PAC-19 clinics. We set up the guidelines, developed guidelines for management of those individuals who are presenting to these PAC-19 clinics. And WHO did recognize Zambia as a country focus where there was a manual dedicated to guiding healthcare workers on how to proceed with those individuals that may have long COVID. For the individuals who are presenting to our clinics, they needed to have at least 4 weeks of symptoms after acute care from COVID-19. And because of our low human resource capacity, most of our guidelines are protocolized, so we have to use protocols for a lot of nurses that we depend on, and also physician assistants in how to manage these individuals. And unfortunately, again, there are not many answers even up to now which we are giving to the people that are suffering from long COVID. So I will present what we analyzed from the data of the individuals that presented to these PAC-19 clinics from August 2020 to January 2023, which was in the REDCap. And we looked at, we did the logistic regression models for cross-section and also longitudinal assessments for those that had more than 2 visits. We also had to look at factors which are associated for what we defined as long COVID. This is our patient flow, a small number, 1,359, and the individuals that did present to our clinics. And of those, we had a huge number of them falling off care. And over time, you can see that from visit 1, where we had 548, we had 50 up to visit 50. A lot of people were not coming back for care, largely as well because we are not offering them much. Most of what we are offering them is counseling, and of course some were referred to specialized clinics as well. But we've continued giving service to those that are still in care. This is just the characteristics of the population. So those that were coming in the COVID-19, the clinics, the post-COVID clinics, we asked them with symptoms, largely fatigue, those that had cough, those that had brain fog, and those also that had difficulty in routine normal functions as well. And we classified those as having long COVID symptoms or no long COVID symptoms. And interestingly, as what has been presented here and many publications as well, we saw that there were more females who presented with symptoms suggestive of long COVID, a median age of 53, and we also had the elderly compared to the younger presenting with symptoms suggestive of long COVID. A lot of our patients were from the urban center in Lusaka, where we come from, and because of the Delta had a high number. This is why we had a high number of admissions as well. So overall, the whole population which we have among those with long COVID, still we have a number of individuals who had SARS-CoV-2 Delta variant compared to the Omicron, even though we had widespread number of new infections from Omicron more than Delta, in fact 3 times more than Delta. And the median time in terms of diagnosis when they presented to the facilities was 6 weeks for those that did present with long COVID symptoms. Again, we saw that those that had pre-existing comorbidities, hypertension, diabetes, obesity, cardiovascular disease as well, were the majority of those that had symptoms suggestive of long COVID. Then the vaccination, at least most of our individuals at this time, we are not vaccinated. That's why you see that even vaccination did not have a factor in how many people presented with long COVID. But we had those that had inpatients, those who were inpatients who had been admitted during acute COVID, presenting as the majority, and also hospitalization from 8 days length of stay was a factor as well. Severity of disease, which we defined for those that were on oxygen, those that received steroids, remdesivir, as a factor as well, where we saw majority of those individuals who had severe form of disease did present with long COVID. This is again showing the attendance by date of diagnosis. We see that again, that lighter blue one, that is the Delta variant. A number of individuals still presented with long COVID. They were infected with the Delta variant of SARS-CoV-2. In terms of time, we see that over time, the number of individuals that have been presenting with long COVID has reduced. This is by the symptoms. We have cough, and you can see over time again that decreasing, but fatigue is still a common feature among the patients that we have been seeing over time. Shortness of breath, brain fog as well is also another feature which has been persistent over time. So we see that you have symptoms for those that have had more than 4 visits. A number of them still have those symptoms which have persisted over time. So when we look at the hospitalized individuals who presented with long COVID, from the 919 individuals in the database, again, we see that the female were more. Then also when we look at the age group as well, the elderly, but interestingly as well was the pre-existing comorbidities. These were a risk factor among those who were hospitalized. Also, the length of stay as well was a major factor. Those that stayed for more than 8 days in hospital, and even those that had severe illness. Vaccination was not a major factor for long COVID development, but those that were referred to the specialist services, and again, these were the sicker people, so they were likely to have long COVID as well. For when we combined those hospitalized and also non-hospitalized, still it's the same factors of comorbidities, hospitalization, which were dominant as risk factors in this population. So in summary here, really we demonstrated that even in a resource limited setting, it's feasible to set up a clinic dedicated to long COVID, and that there are symptoms which were varied and also over there happening over time, and features which are suggestive of severe disease, longer hospital stay, use of steroids, and IV antivirals as well, including the comorbidities which appeared to be risk factors for both hospitalized and also non-hospitalized patients as well. And we believe that moving forward, integrating these services into routine care would improve access. And we have even set up now virtual clinics for some of the individuals that we are receiving. Now, we have limitations to this because only the patients who attended the PAC-19 clinics, and this represented just less than 1% of the entire confirmed cases of COVID-19. Then also, there was a self-report, and so you cannot rule out any self-saving bias as well. And we utilized the routinely collected data, so we had some missing information, and the patients were not retested for SARS-CoV-2, so we could not rule out if there was any reinfection. But those that did present over time with persistent symptoms, which were suggestive of acute COVID, we did retest them as well. We, in the next steps, are combining efforts with other groups from South America, from the UK, and also from the US and Canada on trying to categorize any subphenotypes, because we see that especially South America and also Africa is underrepresented in many of the studies. We want to see if there are any differences looking at the plasma proteins and also the metabolites as well. Thank you so much.